I'd like to welcome everybody this afternoon to PocketMed's first webinar. We're very excited to have everyone here, and I can't tell you how thrilled I am to be able to announce the latest features and our product feature sets that are available in PocketBilling 4.0. As you know, we've worked very hard over the last year and a half to develop this new software, and it's a real pleasure to introduce this to you as it's grown out of a humble office-based software in my practice as a family physician into a full-featured product that can interface with practice management systems, billing companies, and hospital legacy systems. Today I'd like to take a few minutes of your time to show you the great features that are available in this new product and how you might use it as you round in the hospital, nursing homes, or in ERs, or in your various procedure locations for various specialists, and also in your office-based setting. I'm going to put up a view of PocketBilling here and run through some of the various features that can be used. As you can see, the initial screen that shows up when PocketBilling is open is the rounding screen. I have two patients listed on here. I've listed them by their last name and room number. Of course, you can sort by last name by clicking on that field and sorting it, or by room number and sorting it as well. The other great feature here is that we have a hospital selector up here in the right-hand corner that allows you to put in your own hospital or any of the hospitals that you round at, and it allows up to 10 at this point. I think you can add more if you'd like. And you can also keep a discharge list where patients that maybe are frequently admitted can be put as well. Another place that you can bring patients from is from the patients database, where a list of your patients can be populated in here and synchronized either via desktop, practice management system, or just via your own hand entry. The great thing about PocketBilling also is that it's organized the way a doctor would want to round, as it's designed primarily by physicians in practice, including myself. The first thing you would note is that we have a field that says whether or not they've been seen today or rounded today or rounded any date, which is very similar to how you might go through a hospital on a given day and cross off the names of patients you've seen and then later maybe do the billing. Or if you do the billing at the same time, I'll show you where the billing screens are as well. The other view here is that you can have admitted patients, discharged patients, or all admissions. And last but not least, notice that if you tap on the PocketBilling 4.0 thing up here on the top on the menu bar, you can get to different actions which will allow you to send records to your email or to a printer, or you can even beam them to your colleague. You can also move them, and we also have our basic help screen. We'll go through some of those features in a few minutes, but I wanted to show you first of all a basic patient view here. This is Alice Jones. Let's say I wanted to add her medical record number, and at this point my mouse that you're seeing is the stylus that you would be using on your PDA. I'd like you to notice is that we've designed the new version so that all of the buttons can either be tapped using a finger or a stylus, and in particular when entering a medical record number, if you did have to enter a patient on the fly, it's very easy to enter the numbers. They're the size of your index finger, and it's easy to save a medical record number. Once again, you don't have to enter each patient. You can, but it's also easy enough to have them entered onto your desktop system, or also have them synchronized via your practice management system, or an interface with your institutional system, which can be set up with institutions as needed. In the middle, you'll also note that there is a last rounded field, and this is to help you keep track of the patients that you've seen. So if I said today, if I've just seen this patient and said I've rounded on her and saved this, you would note that if I put rounded today, she should drop off of the screen here. I'm going to go ahead and go back to rounds. Actually, what I would want to put here, I'm sorry, is not seen today. All of the patients would drop off because I've put in a name for them already. So let's go back to the ones that we've already rounded on today, and I'm going to give you an example of how you would enter a full patient on the fly. Normally I just put a few identifying fields, as my billers can usually match this up with other hospital records, but I'm going to put in myself here. What I'm doing is I'm typing in using my keyboard on the Trio. Using this keyboard, you can also use graffiti for entry or other methods for data entry. Once again, once you get to the medical record number, it's easy enough to just enter that and save. And let's just say that for right now, I'm going to say that we haven't rounded yet. So we'll get back to our list here and say not seen today, and we'll see that this is one patient I haven't rounded on. When I open this, the best thing to do when you first see a patient is make sure they're admitted to a particular hospital. It should default to Hospital 1. It'll give you an admit date, and if you haven't discharged them yet, there'll be a no date, obviously. It's a good idea to put in your room number so you'll be able to keep track of them, and you can also sort based on that. And the next thing you would want to do is enter a visit on the patient. In this case, it's going to show all visits, and there's none listed. So I'm going to select a new visit. It gives you the medical record number link, the date of the visit, which you can change if you're doing this after the fact. And you can select up to 4 diagnoses for your initial visit. What it'll do is bring you to an alphabetically listed list of diagnoses. We include the top 1,500 ICD-9 codes for primary care, but this list can be customized for your practice. We can make it based on your own super bill. We can make it different versions for different specialties, which are available for download on our web. They're called plugins, and we keep these up to date. And also we update this list of diagnoses every year so that your software never becomes outdated. It's also very easy to get into this list. I'm just going to type the first few letters for hypertension, and I've typed in HYPERT, and there you go. You've got hypertension benign. You can certainly add the next thing, which might be renal failure or something along those lines, renal disease end stage, or renal insufficiency. Some of these have changed. They're now chronic kidney disease, and you can save that as well. At this point, if you wanted to add a charge on here, you can select whether it's either an initial, subsequent, an ambulatory charge, procedure, or if you tap on the more, we get ER charges and nursing home charges as well. I'm going to cancel that and go back to the visit, open the visit again, and let's just say it's an initial visit. One of the things that we spent a lot of time on with PocketBilling 4.0 was a evaluation and management code decision support tool, so that based on the 1995 or 1997 Center for Medicaid and Medicare Services guidelines, you can help yourself to select a code if it's something that you're not familiar with. And I've got to be honest with you, since I've started using this in my practice, a lot of times even when I'm not using PocketBilling for charging inpatient, what I will notice is that as I'm doing an office visit maybe for a complicated patient, and I might be thinking, gee, is this a level 4 or a level 5 visit, I've been surprising myself that actually I've been undercoding quite a bit. Even though I know the rules very well, it just is something that we as physicians are not trained to memorize. And so this E&M coder can really help you as you try to make decisions on which codes to use. In this case, I'm going to select the 1995 rules. They're a little bit more straightforward for the physical exam. And let's just say it's a hospital care inpatient setting. Okay. The next thing you would do is select whether it's an initial visit, subsequent, or consult. This is an initial visit. Obviously, there's got to be a reason for the encounter. You need to state that as well. Once again, all of this has to be backed up by documentation, but that shouldn't be too difficult to do. The history for present illness includes having up to 4+ points for that. And if you wanted to know what that meant, you could tap on the little question mark up there in the right-hand corner, and it's going to tell you that, well, this is based on location, severity, timing, and modifying factors, and you get 1 point for each. So anytime a patient presents, you have to have at least one case of an acute exacerbation of something or describing a problem that has to be described in some detail, just as we learned in medical school. You know, where is the pain? What type of pain is it? What are the aggravating and relieving factors? If you're practicing just basic good medicine, you're almost guaranteed that you're going to have at least 4+ of these. On the review of systems, if you do the full review of systems, it's 10+ and it's complete. And once again, selecting on the question mark up there will give you, the basic review of systems. A lot of us have pre-printed admission forms that have these either reported by the patient, or we can check them off, or a nurse can check them off. All we have to make sure is that all of these are reviewed, and that we certainly review any of the pertinent negatives and positives for the patient's presenting condition or conditions. Next, you'd go to the history. If you've done a full history, it's complete. Once again, if you need to check, the 3 elements of a history are past history, family history, and social history. We all learned those in our basic history taken, and a lot of times this can be filled out prior to admission by either the patient or admitting personnel as well. Now let's get to the physical examination. I would argue that on any new inpatient admission that you might have, that you're going to do a full physical exam. But if you have any doubts about that, you can look and see what they mean by the different types of exams. And as long as you have at least one element from each of these systems, you can claim up to 8 points, as long as there's eight plus of them listed. So if you have a patient that comes in and you check their vitals, you check how they actually appear, you look at their eyes, their ears, nose and throat, check their cardiovascular, respiratory, GI system, look at their abdominal exam, look at their lower extremities. You're going to be checking their neck usually, their chest. It's a pretty straightforward example that any basic admission exam is going to be comprehensive. Once again, make sure you do it, make sure you document it, but this is a good way to keep track of it. The thing where I think most physicians get tripped up is in this coding in the medical decision-making part, and it's a little bit complex. I'm not going to try to explain it the way a coder would tell you. I'm just going to take you through our coder itself. The first thing is select the number of diagnoses, okay? Now what that is based on are these points. Whether or not you have a self-limited or a minor, stable, improved, or worsening, you can have a maximum of 2. Established problem that's stable or improved, and this is 1 point. Established problem that's worsening is 2 points. And a new problem with no workup is 3 points. You can have a maximum of 1 of those. Or a new problem with additional workup. What I tend to find is that we either have multiple medical problems or a new problem that needs workup, or you have maybe a new problem with no additional workup and some established problem that's worsening. It's fairly straightforward to get to 4 in this setting. Just make sure that those things are there and you document them. In terms of the data that you review, this is one, you need 2 out of 3 of these to meet the level of service. And I find that sometimes I'm not actually reaching it here because you need 4 points where you have to look at their review and order clinical lab tests. We usually do that with an admission. Whether or not you do radiology section or not, that remains to be seen. And other tests, discussion of these with a performing physician. It just depends on the level of complexity of your patient. Certainly many of you may be doing that. In primary care, a lot of times I'll just leave this part blank and jump right through to the level of risk. And in this case, all you have to be able to show is that at least on one of these, on the presenting problem, diagnostic, procedures ordered, or management options, that you've met the level of service. And in this case, most of the times it's one or more chronic illness with a severe exacerbation, at least in my case. Certainly based on the procedures that you order, if you order high levels of procedures, including cardiac catheterizations or emergent surgery, and then management options. If you're doing any kind of surgery, or even if you're getting to the point of looking at the prescription drugs, let's say, you're going to have at least a moderate there. So let's say in this case, let's just give this a moderate. The level of code would be level 2 there. If you go back though and actually selected the I'm going to go through this one more time. And if you had selected in that case, I'm going to go through and just show you the different things that I've selected. An admission history has to have quite a bit in there, but if I had selected that we had done a high level of management there, this would have been a level 3 admission, okay? And once again, I'm going to skip the amount and complexity of data, but under the level of risk, if we've got one or more severe illnesses, and let's just say we go to some sort of surgery, or for that matter, if we have any kind of high-level cardiovascular imaging or diagnostic endoscopies or something to that effect, we would get a high rating there, giving us a level 3. So that's kind of the difference between a level 2 and a level 3 admission. There's a lot of vagaries to this, and it's very difficult to memorize and remember how to use the procedures themselves, the E&M procedures. So this is a good way to go through and just double check every time. It takes just a few seconds once you get used to the instrument, and it should help you quite a bit. You can show all visits, or you can show visits without charges, or visits with charges. So this will help you if you had a visit but didn't have a charge yet added to it, you'd be able to sort that. and then once again we can just click on this button here, come back to the rounds section, and once again I'm going to say rounded any date and get my whole list back. If I wanted to search this rounding list by room number, I can select this right arrow button down here and select it all the way to the point where I'm at the room number, and I can sort this forward so that they are sorted based on either going from the top down or the bottom up. I guess it just depends how you like to round. Another really great feature that I was just showing a little bit earlier is the ability to email charges to your office staff, and we found this to be invaluable. You can access that by tapping up on PocketBilling on the top, hitting Actions, and then Send Records. And what this will do is give you the opportunity to be able to send it via multiple different ways. A Trio, if you have email built in and it's set up, has Versamail set up, and Chatter is actually an email client that I bought myself. And what I'm going to try to do is show you how this will work. And I just hit OK on Chatter, and what it should do is enable me to pick up these billing charges for the day and send them via email directly to my office staff. So once again, I'm going to show you how I would select the records to be sent. Basically tapping on this blue box up in the top that says PocketBilling 4.0 and hitting Actions, Send Records, and hitting the Chatter or Versamail as the case may be, and then hitting OK. It's going to give you a sending message, and this is going a little bit slow because it's not exactly hooked up. But what I can do here is I can just type in my email address here. A lot of times what I do is I just put in the email for my billing clerk, and all I've got to do is hit send, and the records that were attached based on the records that are in your PDA and PocketBilling at the time that you press send will be sent off directly as an attachment on your email. And as you can see, my PDA right now is sending that. So it's a real incentive to use a PDA that has email send capability, but also you can do this via wireless. You can do this in other various methods. There's other ways to send the records as well. You can certainly export them as well to your memo pads. So you can go to Actions and Export Records. And in that case, what I did was I just said PocketBilling Export Records, and now they're in memo pads. So when you go back into the main screen of your PDA, you can go down to M, which will give you your memos, and you'll see that my PocketBilling records are there for the date. This format here isn't exactly as pretty as the others, but it does have the diagnosis codes and has the data service and so on. And then what you can do with that memo is you can either beam it, you can send it, or you can synchronize it to your desktop, and then through Palm desktop you can attach that as an attachment to an email and send it just via regular email to your coding clerk. So there's a lot of different ways. I've got to say that we've learned a lot of them even from our own end users, from physicians and nurse practitioners and physicians assistants out there who are using our product, even some psychologists, and have told us, hey, this is how we use it in our practice. So we're always more than happy to hear from you. To that end, I'd really encourage you to participate in our user group, which is located at osmosis.com. We have a PocketMed users group there. This is a new social networking service that was started here in Virginia by a fellow colleague up in Northern Virginia, and essentially it enables you to share information and to have a trusted network of physicians that you can learn new information from and new ways to approach practice, which is what this is all about. Remember that at the end of the day, the thing that really drives this whole process is that we're really trying to improve patient care. We understand that the systems that are available in practice settings aren't exactly perfect yet. There's certainly a lot of room for improvement, and this is just one kind of easy fix for a problem that we all have, which is getting billing from the office or from your background. And I'm getting a message right there. but it's just one way to kind of improve your medical care and improve your practice so that you can get home at the end of the day and spend some time with your families and enjoy what you do for a living. So I really appreciate you participating in this webcast. We hope to have more in the future where we'll be doing training sessions and showing other features and new innovations as they develop. And we look forward to hearing from you with any suggestions you might have. Thanks.